So a very warm welcome to this Prepare Influenza Pandemic webinar. We've got some really excellent speakers and quite a lot of great science to cover in a short time, but I thought I'd just give you a 1-minute background on the Prepare project, just for those of you who are not so familiar. So this is a large European Union funded network for to harmonize large-scale clinical research on infectious diseases. And this was set up in 2014. And clearly it was the right time to be setting up this sort of collaboration, because we've been able to capitalize on the need for exactly this during the current pandemic. So our aims were to enable a rapid response to severe outbreaks and to provide real-time evidence for clinical management of patients to inform the response. So it's a really wonderful European project involving lots of laboratories and hospitals, but also, very importantly, primary care and potential patients as well. So a comprehensive network. So what we're going to do today is to talk about some aspects of preparing for an influenza pandemic. I'm sure many of you have really heard enough about COVID-19 at the moment, but we need to look forward to what may be coming next. And I think we're all in agreement that it's perfectly possible that the next pandemic is going to be one of influenza. And of course, the Prepare Consortium has been able to do some pretty wonderful things, not only on COVID-19, but also in terms of influenza preparedness. So without more ado, I'd like to move on to our first pair of presenters. We have Chris Chu, who's going to be presenting some introduction to the human challenge studies, and then Cosimo Cristella, who is going to be talking about some of the analysis that's been done. So if I can hand over to you, Chris and Cosimo.
My name is Chris Chu. I'm an infectious disease physician and immunologist based at Imperial College London. I'm going to give a very brief introduction to the human influenza challenge studies that we have done as part of Prepare, and really give the rationale for those. And then Cosimo Cristella in Menno de Jong's lab is going to give a flavor of some of the more in-depth analysis that we've been doing. Next slide, please. So as Peter summarized just now, one of the major aims of Prepare was to develop a network which would be able to respond to influenza pandemics to come. And as part of that, in particular, the Mermaids RE study has done a large multi-center pan-European study of respiratory virus infected patients. And part of the objective of that study was to better understand what determines the outcome of infection. So on the diagram, you can see that following virus exposure, you can simply categorize people into those who resist infection completely or develop viral replication. And of the people who do develop viral replication and infection, a proportion go on to life-threatening disease, but quite a large proportion also remain asymptomatic or minimally symptomatic. Next, please. So if we can understand how to push people from the right and to the left, and really understand the factors that are involved in that, then we could potentially develop better interventions. Next, please. So the issue with large-scale observational trials, though, is that there are certain limitations which can't be overcome. So namely, there are a number of uncontrolled confounders. The exact viral strain and the dose that any individual is exposed to can't be assessed and controlled for. The environment that exposure event happens also is uncontrolled. Furthermore, these observational studies are triggered by symptom onset, and in the case of the larger observational trials in Prepare, these were triggered by hospitalization or seeking primary care intervention. So it's really impossible to understand the whole sequence of events during an infection, and particularly those early events which may be pre-symptomatic. Furthermore, it's really difficult to diagnose infections in some of these individuals. Sampling is always limited, and there's inevitably great heterogeneity of patients, which is an advantage if you can do a large-scale study as Prepared it has done, but is difficult if that's not achievable. Next slide, please. So these issues have been understood for a long time, and influenza challenge studies were first developed in the 1930s. And these are studies where volunteers are deliberately infected with pathogens, in this case influenza virus. And during the middle course of the 20th century, a huge amount of work was done at the Common Cold Research Unit in the UK, also institutions in other countries, which were critical in helping us understand the effect of different virus strains, dose, route of delivery, and immunity. We've been taking this work on, and so at Imperial, we have been doing this kind of work for over a decade now to further understand the host response to influenza. Next slide, please. So the key strengths of these kinds of controlled human infection models are that you can define the viral strain and dose, and you can have extreme homogeneity of study subjects by selecting the individuals that you recruit. And this leads to a very reproducible infection rate, and also allows us to have really unprecedented detail of understanding of pre-infection and early events during infection. And what Cosimo is going to now highlight is some of the strength in the longitudinal analysis and the granularity of that data, which can increase our understanding even further.
Okay. Thank you, Chris. So yes, let's have a look at the results on the time course host response to influenza challenge. I will start this presentation giving you an overview of the design and outcomes of the challenge, and then we will focus on transcriptome analysis and the main results of this analysis, and I will discuss briefly how these analyses led us to identify molecular drivers of disease progression and how these drivers fit into machine learning models to study and to predict different stages of different stages of the infection. We will conclude with final remarks and future steps. The study was designed such that 24 volunteers were included and inoculated with influenza A H1N1 California 049. They were previous to the challenge screened for serology, and excluded. The patients were excluded if they tested positive for if antibodies against influenza were detected. Whole blood samples were collected throughout the study, namely from day 0 to day 10 daily, and we also included day 14 and day 28 as a follow-up. Blood samples were used for measuring gene expression through cDNA, and out of these 24 patients, 13 developed an infection as assessed by viral culture of qPCR, and 11 didn't show any infection. For today, we're going to focus on these 13 positive infected patients, although on the uninfected patients, analyses are still ongoing to understand why they didn't develop any infection. But before entering, let's say, into the core of the results and the analysis, I would like to introduce briefly our analytical strategy to tackle time course gene expression. So I'm going to start showing also in this presentation differential gene expression analysis. This introduction, I think, is also useful for you to familiarize with the terminology. Differential gene expression is basically looking at magnitude of differences in expression levels between two conditions measured by log fold changes and also quantified in terms of significance by p-values. Then we are going to move on to correlation analysis, where we looked at gene correlations to come up with clusters of highly interconnected and tightly interconnected genes that share similar biological functions, but that where these clusters are also known as modules. And within these modules, we are also able to pinpoint or extract genes that play a key role in a specific function. And these genes form, in the end, our set of biomarkers, which could be used for machine learning analysis. So let's look at the results of differential gene expression. This plot shows the number of differentially expressed genes across time. The blue bars show upregulated genes and yellow bars show downregulated genes. And what was clear from this analysis was that upregulation kicked in already at day 2 after infection and tend to decrease with increasing time. But what was really interesting to notice in this analysis was that at day 7 we were able to identify on a cumulative, let's say, level the highest amount of differentially expressed genes, suggesting that at this point something was happening in the host that potentially this point as a particular interest to understand the progression of the disease. I don't know what happened. Okay, sorry. Then when we applied whole blood modular analysis on these genes, we were able to identify a number of modules and actually specifically dissect the transcriptome into different biological functions. What you see here is simply the trajectories of genes within each module across time. From this analysis, it was clear that the early stage of the infection was characterized by activation of genes involved in antiviral response, in general, innate immune response. And after day 5, we saw a change in the transcriptional program that was more pointing towards cell proliferation and cell division. And this was mainly characterized by these purple and tan modules. So in order to better look at this, to have a better grip, let's say, on these modules and genes, we decided to develop this animated volcano plot. A volcano plot basically shows on the x-axis the effect size of differential gene expression, where we compared each day against their baseline. And on the y-axis, we see the significance of these effect size. We overlaid on top of these plots, where each dot represents a gene, information about modules, and we selected genes that within a specific module played a central role. We also added information about time, and the result was quite astonishing. So we could actually track the changes in expression across time, where we can see that from day 2 we see an increase and a constant presence of genes involved in antiviral response. These genes stayed for 5 days, and at day 5 something happened. We saw these cell division genes kicking in and taking over antiviral response. Right after day 7, day 8, we saw another set of genes replacing this cell division, and this was quite interesting to notice. And actually, although these genes in the 10, these 3 genes that remained at around day 9 to day 10 are associated to an unknown biological function, digging into more details, we found that these are genes associated to immunoglobulins and plasma cells, suggesting that the host, that the volunteers were reaching the recovery phase. Okay. So the next question was, would it be possible to use information from gene expression to accurately classify different stages of disease? So we developed a machine learning model to classify 3 stages of infection, and namely we defined ourselves these 3 stages, namely an acute stage, including day 2 to day 6 post-challenge samples, and healthy stage, including day 0, day 1, and day 14 of post-challenge, and a recovery phase, including day 7 to day 8 post-challenge. And we performed the feature selection analysis approach, and we ended up with 2 genes that nicely classify these 3 stages, separates these 3 stages. In order to validate these two genes, we used a cross-validation approach on our training set, on our prepared data, from where we generated the model. And we found that the classifier accurately classified the 3 stages of infection in our data, with an area under the curve of 0.95 and a very low error rate. But this was not enough, so we used an external validation set to see whether these genes also performed in a similar fashion in natural occurring infections. And so we focused on 2 cohorts, one where patients were prospectively enrolled and then sampled every 2 days from acute infection, and another one where patients were enrolled and information about stages of the infection were self-reported as days since onset of illness. Well, what we found is that in the first cohort, in the prospective study, our classifier worked fairly good, with a similar accuracy and very low error rate. Though in the study, in the other observational study, it seemed to not work that good. So to conclude, we have seen that transcriptional modules are really it's an efficient identification of transcriptional modules. It's an efficient approach to detect and isolate biomarkers that have that could help us to predict and classify different stages of the infection. This could have an impact on aiding in planning the proper treatments, but also for diagnostic and prognostic purposes. And for this last point, we are now setting up a study to look into our mermaid cohorts and see whether it would be possible to understand if patients who had longer hospital stay could also be somehow associated with our set of markers identified in the challenge study, but as well as validating whether this set of markers could also have a diagnostic application to distinguish influenza from other pathogens. So with that said, I would like to thank you for your attention and thank all our collaborators and friends from the Amsterdam UNC and the Imperial College. I hand it over to the next speaker. Thank you.
So great example of just what power there is in this European collaboration. So if we'd like to move on now to our next presenter, which is Lenny Durder from UMC Utrecht. And she's going to talk about intensive care therapeutic studies in influenza.
Yeah, thank you very much, Peter. So the title of my talk was REMAP-CAP ITU Therapeutic Studies in Influenza. And if I would have stuck to that task very narrowly, this would have been the only slide in my presentation. Because unfortunately, there's a scarcity of evidence on the treatment of influenza in the ICU. There are actually no randomized controlled trials in ICU patients on the treatment of influenza. So that's very unfortunate. And the last time we had a chance to learn something about that was in the last pandemic, so the pandemic before the COVID-19 pandemic was the so-called swine flu pandemic, influenza A, H1N1. And in that pandemic, there was a lot of enthusiasm to do research. There were a lot of interventional studies and also prospective cohort studies planned, but the actual patient enrollment was very, very disappointing. And at the end of that pandemic, that was evidently less disrupting to everyday life, but still caused a huge surge of patients in ICUs across the globe. In the end, only 2 RCTs got done and 73 patients got enrolled. And the results of that study only got published after the pandemic had finished. So that is something that was frustrating to a lot of intensivists. And even more frustrating, this is not just the case for influenza, but for all CAP. Because if you are admitted with influenza in the intensive care unit, the clinical picture that you have is that of a viral pneumonia, a viral community-acquired pneumonia. So influenza is one of the causes of CAP from the perspective of an intensivist. And there are a lot of guidelines about community-acquired pneumonia. There are also guidelines on influenza, but there is a scarcity of high-quality evidence. And this was actually the reason to set up REMAP-CAP. So REMAP-CAP is not an influenza trial, but the swine flu pandemic was the reason that people started thinking about research in pandemics. And what they actually wanted to do, what the idea was, is that there were a couple of things on the wish list. So the first thing was, why don't we look at this problem from the disease rather than a single intervention? Because what we actually want to learn is how to treat patients who come in with this clinical picture of community-acquired pneumonia. And whether that then turns out to be influenza, there may be specific additional treatments, but it's not one single treatment we want to investigate. We want to investigate the best treatment for this disease. And the other thing on the wish list was, if there's ever going to be a pandemic, or rather when there is ever going to be a pandemic, how can we make sure that the research we're already doing can adapt, can pivot to facilitate doing research in that pandemic? That was the kind of the wish list and the way we were thinking about this. And the reason to choose community-acquired pneumonia is, if there was ever going to be a pandemic and ICUs are going to be involved, the most logical thing to assume is that this is a respiratory infection, most likely a viral pneumonia. And I have to say, we actually put our money on influenza to be the next pandemic. It turned out to be coronavirus, but we still learned a lot. And that's what I'm going to take you through in the rest of this presentation. So what we thought at that point was that randomized controlled trials were actually not very suited for doing research thinking from the disease, and also not very suited to adapt in a pandemic, because you need to establish a sample size, which is very difficult for a new disease, and they are very robust but not very flexible. So what we decided to go with is we decided to set up an adaptive platform trial. And adaptive platform trials are randomized controlled trials, but they add 2 key elements to that. So the first thing is they work under a core or master protocol, much like basket or umbrella trials. And that facilitates you doing a lot of things at the same time, making you very efficient and also kind of more in line with clinical care. And the other key feature is they are adaptive, they are flexible. They use data accrued in the trial to guide the direction of the trial. And I want to explain to you these 2 design aspects of adaptive platform trials. REMAP-CAP is an adaptive platform trial. So the first thing is the flexible or adaptive nature of these trials. So I view this as kind of Google Maps. So in a traditional RCT, you know where you start, which is usually without any knowledge, and you know the address of where you want to end up with the knowledge on a specific intervention. But what you don't specify is the route. You just assume you're going from A to B and you have fixed the way you are going there. But we all know that things may change in the meantime. So for instance, there may be detours, there may be traffic jams, or you may have to cross a body of water where in the time of your traveling, there's a bridge built, which makes your route much more efficient. So things change. And what adaptive platform trials do is they use Google Maps rather than just an address. So they use the information that becomes available while you are traveling to take you with the most efficient route to your destination of acquiring knowledge. And if you put that into a little bit more scientific slide, it looks somewhat like this. And if you start at the top left corner of this slide, you can see that in adaptive platform trials, we enroll patients like in every randomized controlled trials, and we randomize them. That's what you see in the second box. And if you then follow the arrow of the circle, you can see that like in every randomized trial, a randomized controlled trial, we record outcomes, but then it becomes a little bit different because after updating your trial data, you also update the statistical model. So this means that in an adaptive platform trial, during your the running of your trial, you get to look under the hood. So you get to have a sneak preview of the data that is already there. And it works differently from a traditional interim analysis in your regular randomized controlled trial. There is less spending of alpha error, and there's another neat feature of these analyses, which is that you pre-specify what we call a termination rule. So before you start the trial, you discuss and set how sure you want to be that something works before you stop investigating it. So rather than setting a fixed sample size, which you usually do by just guesstimating an effect, you say, I want to be 99% sure that this drug works for this disease. And if we hit that anywhere along the way, then we stop randomizing. So at each adaptive analysis, so we don't call them interim analyses to make the distinction between classical RCTs and adaptive platform trials. At each adaptive analysis, you look at the data that have accrued, and if the data are such that you are confident enough that something works, then that intervention graduates, and that is when you reach what we call a platform conclusion, and then you stop randomizing, and that intervention becomes your new standard of care. But obviously, this is not true at each adaptive analysis. So sometimes you may be, so let's say you're 70% sure that A works better than B. That's not enough to stop the trial. You want to be a little bit more sure before you declare that that has graduated, before you give everybody that intervention. But what you can do, and that's shown in the next blue box that goes up from the red box, is you can update the randomization weights. That's a strategy called response adaptive randomization. And what that means is, let's say if you're 70% sure that A works better than B, you randomize 70 out of the next 100 patients for A and 30 for B, meaning you assign most patients, you allocate the intervention to most patients for the most promising intervention. And that can obviously fluctuate, and it can even go back to 50-50. But while data accrue in the trial and you become more and more sure that A works better than B, you work towards reaching the pre-specified termination rule and reaching the platform trigger as you go through the circles. And what's not indicated in this slide is that when we are running the trial, the data is accruing and we are doing these adaptive analyses, you can also add new interventions and domains to the trial, which makes it very flexible and adaptive. So that's about the adaptive part of adaptive platform trials. That is something in addition to the classical RCT design. So the second neat feature of adaptive platform trials is that they work under a master protocol. So in REMAP-CAP, we call that the core protocol, and that specifies all the things that are general about the trial. And we, even before the pandemic, specified changes that we intended to make during the pandemic, and that's also what happened at the beginning of 2020. And these are things like changing the primary outcome, which we did because our primary outcome before the pandemic was day 90 mortality. But in a pandemic, you don't really want to wait 3 months before your follow-up of all your participants is finished. You want to be a little bit quicker. So we changed the primary outcome to organ support-free days at day 21, still collecting the day 90 outcome because it's an important outcome, but not to drive the platform conclusions. And then that core protocol functions as kind of an umbrella. So there is one statistical model under which everything we do is integrated. And we integrate what we call domains. It's called DSA in this slide. It stands for domain-specific appendix, because for each group of interventions, related interventions, we create a kind of a module in the protocol. So we have an antiviral domain, we have an immune modulation domain, And for those, there are protocol elements called domain-specific appendices. And before the pandemic, we had 4 of these blocks, 4 of these domains for what we called non-pandemic patients in the ICU. And during this pandemic, we've added several more. We currently have 13 domains up and running. Some of them are specifically for patients with COVID-19. Some of them are still specifically for non-pandemic patients, and some are for both. Because, for instance, an intervention like vitamin C, that is something that is promising in both regular CAP and CAP caused by SARS-CoV-2. So we allow both types of patients to be included in that domain. And for the pandemic patients, we include not just ICU patients, but also the less severely ill patients. We call them moderate, and those are more or less the patients you will see on board. So that are the 2 key design aspects that make this type of trial very suitable for research in a pandemic: the multifactorial and the adaptive. And if you then add that it's a randomized controlled trial, that it's embedded in clinical care, and that it's a platform for CAP, then you understand how we get to the name REMAP CAP. So this is a REMAP for CAP, and a REMAP is a kind of a subgroup of adaptive platform trials. And if I look back at February 2020, so a little over a year ago, this was the situation that we had for REMAP CAP. We were active in 5 regions across the globe. We were not actively recruiting in the US, but we were in Canada, Australia, New Zealand, and Europe. And we had 26 hospitals in those regions, including patients, and things were not moving very fast. We had about 118 patients at the beginning of February 2020. Then came COVID. So COVID obviously swooped us like a tsunami, and it also increased the speed of how things were moving in REMAP CAP. And at this point, it's not just the 4 regions anymore, but it's now 310 hospitals across the globe in 6 different regions. Well, that's indicated here, and you can see 3 red dots. These are regions that are in startup, but actually Colombia and Japan have already started recruiting. So we are at 8 regions now, and we are working with colleagues in Africa to see if we can add them to the global REMAP CAP trial, because this is a trial that's truly global. It functions in the same way in all these regions, and there's one overarching model analyzing the data of all the patients included in all these regions. And we were very lucky in the EU that we were able to start this work already before the pandemic under the PREPARE consortium, because the EU understood our vision, and we've been even luckier that they've now allowed us an extension of the grant under the RECOVER consortium for the work done in COVID-19. So that's very, very valuable. And not only have we increased the number of sites and the number of regions, we've also increased the number of things we are investigating. Because as I told you before, we are multifactorial, meaning we can randomize patients to interventions in multiple domains at once. And not even all of them are shown on this slide, but this is what we call the current state. And it neatly shows you the interaction between all of the domains that we are currently running. And this picture only shows you the pandemic patients in the severe state. So in addition to this, we have the non-pandemic patients, so the regular CAP patients, and the moderate patients, so the ward patients, for whom some of the interventions listed here are also available. And what you can see in this slide as well is that there are several kind of X's and green icons and gray X's, and that indicates the interventions that have been proven futile or effective. And you can see, for instance, that for COVID-19, we've shown corticosteroids to work, and that we've stopped randomizing for that. We've also stopped the control arm in the immunomodulation domain, and we've stopped the current interventions in the antiviral domain, and also the immunoglobulin domain, which is convalescent plasma and anticoagulation. You can also see that we evaluate pre-specified interactions. We're able to nest interventions. For instance, for the immune modulation domain, you can see that we nested Y4 and Y5, and you may not know what that is, but it's sarilumab and tocilizumab that we analyze kind of also in a pooled way, nested together. So this current state is the basis of all our analysis. And you can see that we've added at least 10 domains in the last year, which was a huge effort because each domain has to be submitted in all these countries for all these sites as a substantial amendment, which is a huge amount of work. And what I wanted to show you is the fact that it is proving to be effective. So when we set this up, after that influenza pandemic and knowing that there was little evidence in ICU patients, we wanted a trial that was efficient and that could produce results quickly if there was ever going to be a next pandemic. And even though this was not an influenza pandemic, the system of the adaptive platform trial did prove to be very efficient. So we activated the pandemic strata on the 3rd of March 2020, and 6 days later, we included the first pandemic patient in the corticosteroid domain that was already up and running in several hospitals across the globe. In September, we published the results of the corticosteroid domain in COVID-19, and I think you're missing some of the data that was supposed to be on this slide. It's coming now. We've had several platform conclusions since then for antivirals, for therapeutic anticoagulation, for convalescent plasma, and also for the IL-6 receptor antagonist that we published at the end of February. The antivirals, therapeutic anticoagulation, and convalescent plasma manuscripts are all still under review. So I've been telling you about REMAP-CAP, and I've been telling you about what we have managed to do in the last year. But how does this then, relate to influenza? Because the box of influenza knowledge is still empty. But I do think we've gained a lot of momentum, and we've learned a lot of things that will benefit our knowledge of how to treat ICU patients admitted with influenza pneumonia. We are going to be able to fill the box of evidence for influenza with what we've learned in the last year. So I think one of the neat things is, despite the fact that there's a global COVID pandemic, we have still been able to recruit the incidental influenza patient that comes in just because we are embedded in the clinical care. So far, about 100 patients have been randomized to our domain looking at treatment for influenza. And in that domain, we compare not treating a patient with oseltamivir to treating them with 5 days of oseltamivir to treating them with 10 days of oseltamivir, because this was the first question we thought was important. But because of our adaptive design, we will be able, once this COVID pandemic dies down a little bit and we expect more influenza to come into the ICU again, we will be able to add other antivirals to that domain or create another domain if that's necessary. For instance, baloxavir is a very interesting antiviral that I think we would want to investigate, and that can be seamlessly integrating into the trial that's already recruiting patients as we speak. And the other thing that this pandemic has given us is kind of new insights, because I think at the beginning of this pandemic, there were not a lot of people that would have predicted that specific immune modulators like IL-6 receptor antagonists would have an effect on a viral pneumonia in the absence of antiviral treatment. So you may know that remdesivir, even though it may have an effect in the less severely ill hospitalized patients, has not been proven to be effective in the critically ill patients with COVID-19. The immune modulators, corticosteroid as kind of a broad immune suppressant, and the IL-6RA, they've proven to work in that viral pneumonia. And obviously influenza pneumonia is something very different from COVID-19 pneumonia, but the fact that immune modulators in the absence of antivirals have been effective in this pandemic opens up a whole new way of thinking, if you want. It opens up a lot of possibilities to want to investigate that in influenza patients in the ICU. So I think that's also what this pandemic has brought us in learning about influenza in ICU patients. So to summarize, I think REMAP-CAP we had a global network, but it's become even larger, which is very important if you want to recruit patients the whole year round in a way that yields results that are generalizable to the whole ICU community. So I think that's one of the things that we've achieved in the last year. The second thing is we've proven that the approach of the adaptive platform trial, being adaptive, using the data that accrues, and also being multifactorial, that works even in a pandemic. So that could benefit our influenza research. And as I said before, we have continued to evaluate the best treatment for influenza. And we have a lot of opportunities to fill the box of evidence-based medicine for influenza in the coming weeks and months. So I'm very happy with that. I'm looking forward to focusing on influenza again, in addition to or instead of COVID-19. And I think the last thing I want to say is just a huge thanks to everybody globally that we now refer to as the REMAP-CAP family, all the people, all the researchers, all the supportive personnel that have made it possible to run this trial, to scale it up the way we did, and to make sure we have built the infrastructure and the base to continue investigating the best treatment for CAP, and that very much includes influenza in the next months and years. If you want to follow us for updates, you can follow us on Twitter, LinkedIn, Instagram even, or you can listen to our podcasts that are available on iTunes and Spotify. And with that, I'd like to thank you for your attention, ask you to put any questions in the chat, and hand the word back to Peter. Thank you for your attention.
Thank you very much, Lenny. So we are slipping a bit on time. But when we have a couple of really good presentations, we're inevitably going to move a little bit into the question time. But let's move on to hear from Philippe Beutels from Antwerp, and also from Chris Butler from Oxford about the health economics and cost effectiveness of therapy. So see if you can make up some time.
Certainly will. Thank you very much, Peter. Warm welcome to everybody, and thanks for the privilege to present today. So I'll just introduce the ALICE-4 trial, ALICE-4E trial, and this is the oseltamivir cost effectiveness for treating influenza in Europe. Next slide. Now, the background to this is that oseltamivir is a widely available drug for use in flu. And well, perhaps I should just say we'll present the primary analysis of the main trial, then move on to the costs, direct and indirect costs, and the health-related quality of life analyses, as well as the cost-effectiveness analyses. And Philippe will present the health economic side. I'll just introduce the trial. Next slide. So lots of money is spent on Tamiflu, apparently 500 million euros a year. It's been approved for a long time. And the only sorts of trials that are available are trials funded by Roche Pharmaceuticals. And these are usually placebo-controlled efficacy trials. And they've been questioned repeatedly around publication bias. And they answer a question really of does Tamiflu work better than a dummy version of Tamiflu? But we don't know whether it is useful really to prescribe this stuff in the real world setting of primary care. And furthermore, we don't know what the cost effectiveness is of that. So we set out to determine not whether Tamiflu is better than a dummy version of Tamiflu, but whether adding Tamiflu to whatever else you do to usual care is cost effective for people with influenza-like illness. Next slide. So we can move on to the next one as well, because I've just said that. And the following as well, please. We stratified people by age, severity. These are people presenting in primary care with influenza-like illness. whether they had comorbidity or not, and their symptom duration. And we defined influenza-like illness according to the ECDC guidelines. And then we took a swab on everybody who was recruited before they were randomized. And those swabs were analyzed for flu status and other bugs. We found that almost half of the people actually were tested positive on PCR for flu. Next slide. We got over 85% of these participants with the primary outcomes, and we did the study in 15 European countries, in 21 primary care networks over 3 seasons, and we had a reasonably good spread by age group. And you can see the recruitment by countries there, with Catalonia leading the way in terms of recruitment, but it was an individually randomized study. Next slide. And this is the outcome that is taken from the publication in the Lancet. And essentially what this shows is that on average, people got better at exactly the same rate as we found in the Roche trials that I mentioned, and indeed in all the meta-analyses that were done on those and on those trials. So people get better on average by about a day. However, our trial design allowed us to look at differential benefit by age group and illness severity and comorbidity. And in a nutshell, those people who are older, who have more severe illness and with comorbidity might get a 3-day benefit from oseltamivir treatment. So I'll stop there and ask Philippe to take over and present the novel and exciting health economics data that this study generated.
Thanks, Chris. Yeah. So we collected also, as part of this trial, cost data and health-related quality of life data. For the cost, we had 2 approaches where we asked people for how much they spent directly themselves, but we also, of course, were monitoring their resource use, so how many packages of medication, how many visits to a doctor, and so on. And later collected country-specific information for all these different countries on the unit cost that these countries charge for these particular medical acts. So we had 2 ways of costing, and that's given at the bottom left part of the slide, where there's a quite a long process of getting all these data ready and to combine it with the trial data, where we've been monitoring people in terms of costs on everyday medication use. We had written questionnaires on day 1, 7, and 14, and telephone questionnaires on day 14 and 28, where we looked back also on their experience related to hospitalizations. On the quality of life side, we had recording of the visual analog scale score, which is kind of a thermometer scale that you might have heard of, and the Eurocall, which is the most widely used multi-attribute classification system for health states in the world, and also very applicable to Europe. And we used that both for the adults over 13, as well as the child version for children under 13, who were filling this out either themselves or jointly with their parents. So that's one of the caveats of the study, of course, since it's there are still some problems with the evaluation of kind of measurements. We used statistical methods to deal with the responses on the quality of life scales, where we modeled the odds to get a perfect score, as well as the score when they are not perfect. So this is what is called one inflated big data regression, and looked at covariance of interest. Next slide, please. Cost effectiveness analysis was done from 2 main perspectives, so the healthcare payer and societal. We looked at 14 days. From what I will show today, we're also looking at the 28 days result, but here I'll just show the 14-day result because that was all written. As you remember from the previous slide, perhaps, the 28-day interview was by telephone, so that's a different way of recording the quality of life than in writing. So we just want to stick to the 14-day written evaluation after day 1 and day 7. We used the approach to costing that I just explained, and we bootstrapped from the cost and the effect distributions to get cost effectiveness results. Next slide, please. So next slide. In terms of costs, we do see that the average direct costs were lower, so the direct medical costs of healthcare were lower in the peer group. So we use different perspectives, but they were all lower for the oseltamivir group, but not statistically significant. This is also shown in the figures on the left, where you can see that the bars are overlapping. While the point estimates within those bars tend to be lower for the oseltamivir group for different perspectives. The results are quite robust for the different age groups and different assumptions that we use to calculate costs. So we looked at this in different ways. But we do note there are important country differences. Next slide, please. This is an evaluation of the health-related quality of life reported in the trial. This is the results for adults and adolescents, so over 13 years. On the left, this is after a 14-day follow-up, where you can see there's a clear lower quality of life estimation for the group that doesn't receive oseltamivir, and that difference is estimated to be 0.006. I forgot a zero, 0.0006 QALYs, and with the 28-day follow-up, it's 0.0008. So we use this entire, the surface of the difference between the two curves that you see on the left in what I will follow. We will use that to estimate the utility gain from the intervention. Next slide, please. So this is a kind of a busy slide. The results of the analysis on the left, you can see these scatter plots. These are cost effectiveness planes, where the vertical axis is indicating incremental costs. So above the zero line, you have excess cost. Below the zero line, you have savings. And on the horizontal line, you have, on the horizontal axis, I should say, you have incremental QALYs. So on the right, you have a gain in QALYs. On the left of the zero, the origin of the axis of the plane, you have QALY loss. And what is shown in the top row is adults, in the bottom row is children. And through the sheer distribution of the scatter plot, you can see that the uncertainty is much higher for the children group than for the adult group. And this is related also to the number of data points that we had, but also the uncertainty related to both the QALY gain and the costs associated. What you see within the scatter plots are 2 points, and the orange is from a payer's perspective, showing the expected incremental cost utility ratio, which for the adults is 22,000, and for the societal perspective, it's dominant in the sense that it is below the line horizontally and to the right of the line vertically, which means it's both cost saving and gaining health. So that is a very positive result, of course. And at the bottom line, bottom row for the children, we also see that these dots have, on average, an expected value in the area of about 10,000 euros, let's say. So the other curves are showing the uncertainty associated with the wide distribution. And in the middle panel, you can see the probability of having a cost-effective result given the willingness to pay value for a QALY that the decision maker is willing to pay. So the more to the right, the more they're willing to pay, and the less uncertainty there is in the decision. We can see that the decision uncertainty is much larger for children than for adults. So all in all, the oseltamivir group can be on average cost effective if the payer is willing to pay at least 25,000 per QALY gained, and can be cost saving from a societal perspective. You have to take into account that we use the list prices of oseltamivir in all these different countries, and that there are important differences between the countries, which are here put all together. Next slide, please. So, in conclusion about these preliminary results, I should say, overall, the primary outcome analysis showed that the duration of illness is shortened by about 1 day. It improves the health-related quality of life. This is a significant result that we find, and it is likely to be cost-effective from both perspectives that we considered in Europe. But there are variabilities between age groups, risk groups, and individual countries that we're currently trying to explore a bit more when we're writing up this analysis as a paper. What we have to keep in mind is, of course, that the pragmatic trial observed current practice, as Chris explained, so potential placebo effects over and above usual care can be absorbed in the oseltamivir group. But another aspect is, of course, that the indirect effects of reductions from these antivirals in onward transmission is ignored. And thank you for your attention. And maybe I should show the next slide to acknowledge, of course, all the people involved in the data collection. It's a huge effort from many people, from which we are extremely grateful that they're willing to work with us. Next slide, please. And you can see a picture of them in the next slide.
Well, thank you very much, Philippe. I think, again, a wonderful example of how pan-European collaboration works so well. I think we're all looking forward to getting back together and meeting in person, aren't we? So we should move on to our last presentation by Alistair Nicholl from University College Dublin, talking about this really critical question about how to get the public involved and how to involve patients in our preparedness. I think it's become evident just how important this is in all aspects of research. So Alistair, over to you.
Thanks very much for that. What I will do is we're just, oh, 1 second. Apologies. There we go, perfect. So thanks very much for that. And yes, look, this is a really important topic. And look, I will reduce the length of my talk because there's a lot of questions we should get through at the end. And I can pick up a number of issues when we get to the questions. But let me start. So, and like the other speakers, it's a great honor to be asked to speak today. And I really have to start at the start of this by acknowledging the other members of the work package. So our team was called EARL, which stood for Ethical, Administrative, Regulatory and Logistical Barriers. And our focus was to find the barriers, but to develop solutions, and to develop solutions that would be useful for a future influenza or other pandemic. And I worked with Chris Butler and Steve Webb we managed 3 teams across Ireland and Dublin, Cardiff, Oxford, and the University of Western Australia. And the work I'll be talking about today really has been conducted by the whole team, but in particular Nina Gobbett, who will give a presentation next week as well. So, but if I can bring you back to 2014, and maybe those photos would show how long ago it is for some of us, that well, what did we do first, and how would we aim to address this problem? Well, we actually did a report that really identified what are the barriers in each EU member state, because we're focused on the EU at the start. What are the problems of getting a pandemic study through ethics and through regulation? And as part of this, we actually spoke to people in ethics committees, regulators, and clinical researchers as well. And I mean, a lot of the usual suspects came up, clinicians too busy, problems with contracts, but consent came up as an issue identified by all of the people conducting the trials. And that had a particular resonance for us, because consent is the perfect intersection between all the various oral aspects and the patient voice. It is a common area where actually it is probably the patient's or the patient's family first encounter with clinical researchers within the healthcare system. And it is an area where we need to make sure that the interactions are efficient, transparent, and actually that we get the information necessary across from both sides. So it seems an ideal place for us to start to tease out the patient's voice to improve what we do in our PREPARE trials. So, well, where did we start when we wanted to understand the public attitude to pandemic research? Well, as everything, you go backwards first. So we looked at research in acute or emergency situations. And the reason we did this for twofold was that, well, obviously a pandemic is an emergency situation. In my day job, I work in an intensive care unit. So many of the patients who I see are unfortunately incapacitated due to their acute illness and are unable to take part in these discussions themselves. So we have to involve their next of kin. And when we looked at this literature, we looked at a number of studies, and they showed that actually the public are generally pretty trusting of the healthcare community, of doctors, of the various models of consent we currently use, which either are, I sit down with you as a researcher clinician and have a discussion with you. Unfortunately, like in my practice, if you're incapacitated because of your illness, I would speak to a next of kin. Or in some countries, there is legislation that allows me to talk to an independent doctor so that I can get permission to enroll you into a study until you have the capacity to consent yourself. And the public are supportive of this. And interestingly, they were more supportive of these models than the ethics committees and the regulators. And I suppose that reflects the conservative role these bodies take in overseeing patient safety. But I suppose it has to be balanced by the patient's right to take part in studies, and particularly in the context of a pandemic. And interestingly, when we looked at this literature, most of it was involved in trauma and other emergencies. Only one of the papers actually addressed pandemic relevant research. So again, this was a critical evidence gap. The next stage, we actually, well, if we wanted to focus groups in 4 EU member states, and we also conducted some structured surveys and to talk to patients about what their attitudes were to these topics, what other things they thought were important. And the whole idea of this was twofold. Now, obviously, we published our results, but it was to create patient-facing documents, because only too often some of these findings end up in medical journals, which are not easily accessible by the public. So the team led by Nina created these public-facing documents. We put them on our website so that people in the community could see what we were doing and what the main themes were. And again, but the final goal of this was actually to develop a survey that we could actually bring not to tens or hundreds of patients, but to thousands of patients to get their attitudes across the EU and also in other regions where our trials were taking part. And that led to this large cross-sectional international survey. And I might spend just a little bit more time on this. So, well, what was the aim? It was to basically talk to patients about their attitude to participation in a future influenza pandemic. It was international, and we actually ran this in all of the countries at that time that we thought REMAP-CAP, which Lenny talked about, would be participating in. There were nearly 7,000 participants in 8 countries, and Ipsos Mori helped us with the data collection. And we collected this data during the winter flu, both in the northern and southern hemisphere. so that we thought it would focus patients on the public's mind. Well, in sort of brief, what were our findings? Well, the respondents felt it was really important to do clinical research during a pandemic. 80% plus felt that was the case. And also, in addition, that special rules should apply to make it easier to conduct such research during a pandemic. We asked patients whether they would be willing to take part in two scenarios, one in intensive care, and this first one in primary care, and one was low risk, which was two treatments, both proven, both safe, but to see which one was better. And a second, a high risk scenario where one of the treatments was unknown, so it might have more beneficial safety, but it might have more beneficial efficacy, but it might have actually safety implications as well. And what we can see here in the orange and the sort of mauve is that the vast majority of patients either strongly agreed or agreed to participate in the research. And if we go across to the left in the blue and the red, only very small numbers of patients felt that they did not want to participate in the low risk studies. This was the same when we went to the high risk. Now the numbers were not quite as high, and some more patients were less interested to take part in high risk studies, but overall the respondents were strongly in favour of participating in these research studies. If we asked them actually how they would like to be enrolled in these studies and what were the main factors when we talked to them that they would want to know was, well, only 10% wanted to be included automatically. The rest wanted to be given an opportunity to consent to the study. Nearly 30% were happy to be included automatically, but be given an option to opt out later on. And just over 60% said, sign me up when we get to that point. And this was pretty much the case across the low risk and the high risk in the primary care setting. And again, this reflects our current practice. In drug trials, we will consent patients at a point of care to see whether they wish to participate in the studies. But it's interesting that there are numbers of patients that for maybe some studies with lower risk and maybe not involving pharmaceutical agents, that other models of consent may be acceptable. So I just highlight that again. And again, interestingly, we found there were some things that had an impact on whether people were likely to want to participate in the studies. There were some country differences, but actually the things that really strongly predicted whether they want to take part or not was knowledge of pandemics, previous experience in ICU, and trust in the government. When we look at the ICU scenario, again, we see the same pattern. There's an overwhelming majority of patients are agreeable to participate in these studies, both in the low risk and in the high risk settings. And again, it's reasonably similar across countries. But again, bearing that in mind that a number of these patients may not have the capability to consent, there's different models. So if we look at the first two columns, we can see that actually, if we combine these together, the majority of people are happy to be included as long as a family, or in some cases which allow it, but a doctor is allowed to say whether it's okay for them to continue or not. A small group of patients, just over 10%, said include me immediately and don't ask anybody. And the second largest group, 42%, said don't include me until a family member says yes. And again, this largely reflects current practice, that for higher risk studies or studies that involve pharmaceutical agents, consent is required before the patient is enrolled. But for low risk studies, where time is of the essence and there's a public need, these patients can be enrolled without their direct consent, but that is obtained later on. So again, the public are broadly in agreement and supportive of the current consent methods used. Again, we find the same factors that are involved in patients' willingness to partake in the studies, with previous ICU experience and trust in the system. Just very interestingly, we found that the use of biological samples, patients were strongly supportive of us using samples that were collected as part of routine clinical care for research. And they were happy for these samples to be used during a pandemic, to be used after the pandemic. This also included the use of their genetic material and for future clinical research. So the headline findings in this survey were that respondents are willing to take part in clinical research during a pandemic. Trust, attitude, and experience makes a difference. Public education engagement is a vital part of pandemic clinical research preparedness. Traditional informed consent is still the preferred model, but alternatives are acceptable to a significant minority and may be more suitable for certain low-risk studies. Support for the use of excess routine clinical samples, including genetic material, was largely supported. However, knowledge, experience, and trust is key to increase the acceptability. And I'll just pause there for a second to say that this research that we did was actually useful during the COVID pandemic. It actually informed our interactions with ethics committees and regulators. And there's many other things that I can't talk about today just because of time that we are also doing to engage with the public, to hear their voice, to tailor their voice, to make our studies better, but also to make the studies more accessible to our patients and their families. Thank you very much.
Well, thank you very much, Alistair. So if I can ask the panelists to all put their cameras on, and if you want to say something, just physically put up your hand on screen so that we can see your hand waving. Yeah, so fascinating presentations. I think just again showing how wonderful it is to be able to collaborate as we have been doing. And I very, very much hope, to speaking from the British point of view, that we can continue all these great European collaborations despite the decisions of our politicians. So quite a few questions. I think we should finish at past in a quarter of an hour, as we said we would. But if I could perhaps go first to Chris, and Kerry Hood was saying, what about the ethics of the challenge studies? You know, how can you balance the risks and the benefits? Can you just very briefly give a few headlines about, you know, whether it is ethical and whether the ethics are uniform across Europe? Do you think some things are ethical in some parts of Europe and not in others?
Well, I think this is a critical question and really very complex. So you know, we could spend hours talking about it, but the fundamental principles are that you need to balance the risks to the individual participants taking part in these studies with the overall benefit to society. And for some challenge models, that's relatively straightforward because the pathogen, whether it's flu virus, whether it's Salmonella typhi or malaria, they are either known to be completely self-resolving with no long-term complications, or they are completely treatable with antibiotics or antiparasitic agents. And in those settings, I think it's the societal benefit definitely still needs to be there. You need to justify these studies very clearly, but at the end of the day, the risk of harm to individuals is low. And if you can fulfill those sort of basic criteria, and then there are lots of sort of feasibility, safety sort of issues that you need to fulfill, then I think that it is justifiable to do these studies, particularly because these studies have the ability to answer questions which can't be answered using any other kind of study design. I think if you could replicate these findings in other types of studies, again, that would make it more ethically questionable. I think there are different attitudes towards this around the world, and that's definitely true. But I think that is gradually expanding, and people are having these discussions, and regulators are now having very intensive discussions, mainly in the context of COVID, about the potential for challenge study data to be used as part of regulatory packages for emergency licensure. So I think there is, as understanding of these types of studies increase, and as public understanding and the ability to really achieve proper informed consent amongst volunteers increases, then I think the ethical acceptability also increases.
Okay, does any other member of the panel want to make any comment about that? Alistair, do you have any perspective on this, looking from the point of view of different countries? Just in brief.
Well, I mean, very, very briefly, I'd say, I mean, they're probably ethical. If it's ethical in one country, it'll be ethical in another. The question is it acceptable? And I think that's a very different question. And I think that's where you really have to engage with the community, their understanding, maybe previous time researchers have not covered themselves in glory can affect public attitudes quite largely in countries, and I think we've seen a little bit of that before. And I think that's where it comes around to us as the researchers and the clinicians to be very clear about what we say, to be very transparent, and to aim to build trust every time. Because only when you have trust can you try and explain something complex like this, like Chris was talking about.
Okay. So Philippe, what do you, are your fellow people, is there more reluctance about accepting things like this in your country?
Was it addressed to me? I'm not sure.
Yes, it was. Sorry. Yes. Yeah.
I'm not sure. I can't really tell.
Okay.
Can't speak for the population.
Well, let's move on. So, Lenny, lots of questions for you. Questions about how REMAP-CAP could possibly have been even better. How can you sustain it? Did it lead us astray in terms of our response? In brief, what would you say?
Yeah, thanks, Peter, for that question. So every trial can always be improved. I think the interesting thing is that the delaying factors, the factor that prohibit us from moving fast, are the same for adaptive platform trials, at least for REMAP-CAP, as they are for traditional trials. And there are two things that always take time, and this is also work done by Alistair and Nina Gobat and their group in Prepare, is that it's always contracts that take a lot of time, and the submissions. And you can imagine that if you have to do 11 or 12 substantial amendments in a year in 12 European countries, there's a lot of work that goes into all the administrative stuff and translations, and waiting for approvals takes time. So I think that's not different for an adaptive platform trial compared to regular trials. The good thing is that because you're global, you can move, as soon as you are allowed to move in every region or country, in every kind of jurisdiction. So that's nice. I do think when our kind of global family was growing so fast as it did over the last year, and we were taking on so many new things, we did have to kind of internally reorganize a little bit, so that because we couldn't all be involved in everything anymore. But I think the fact that we had strong bonds and trust built since the Prepare seed funding in 2014 really helped us establish that. So if you say, kind of, did this lead us astray, or was it functional? I think it was very helpful that we had done the preparatory work that we did before this pandemic. We've said during this last year that we wanted it to be COVID-20. We would have been a little bit better prepared. But I think, if it would have been COVID-20, we would have said we'd like it to be COVID-21, because you're never fully prepared. But I'm confident that all the work that we did in Prepare really allowed us to ramp up as quickly as we did in the last year.
And Peter, I might just add something to that. So Lenny was talking about all our interactions with ethics committees, and I have to say the work in the Earl work package really helped that. So sure, it wasn't COVID, it was influenza, but in some of the stuff I talked about, we had actually talked to patients in advance, and we were able to say, do our public think this is a good idea? And we say, actually, we surveyed your public, and here are 800 responses from your country. And so that was very powerful, and I think it speaks to the power of PPI. And the group in Cardiff and now the group in Dublin set up public panels of people from the public and ex-patients, and we're able to ask them questions of REMAP-CAP and show them patient information leaflets, and is this accessible, and do you understand this, and can we make it better? So those interactions, Prepare will have left that legacy, but the REMAP-CAP, as Lenny says, the family's getting bigger. Canada is doing the same, and that's going to expand. So there's going to be a PPI part of Remap Cap that will allow us to, to resonate the public voice as we go forward. So that's another advantage over.
And Alistair, just another question just come up. Do you think attitudes have changed during the pandemic? Do you think all this coverage that we're getting in the media has influenced the way in which the public regards research and?
Yes, I think there's been ups and downs. And so, I mean, the ups would be, I think if you repeated the work we did now, nearly 100% of people would say pandemic research is a good idea. We asked people, should the rules change during the pandemic? Well, actually, the rules did change during the pandemic. And a number of the countries for Remap Cap almost completely changed the rules to make it easier. And it would be really interesting to ask the public's perception of that. And I think the public would say the wins are the regions and the countries who got their trials up and running quickly and got results for their populations quickly. So I think you would find more support for those sort of things. Maybe where we let ourselves down or the community caused some confusion would be when scientific issues became political issues and there were experts on TV saying country points, and it would be hard for the layperson to make sense of that. And I think where that leads it to is, institutions like, Prepare and etc. to provide sound, independent advice. So a mixed bag, but I give us a B+ overall.
Okay, great. So Philippe and Chris, so your analysis shows that some benefits are personal, some benefits are in terms of transmission, some benefits are to the employer. Who do you think should pay for oseltamivir?
Philippe?
So when we do this analysis, we are combining the healthcare payer's perspective, which is both the system and the patient's co-payment. That's one part. So that's a healthcare payer perspective. And the other part is society, where we add everything else that is considered to be relevant in most guidelines for economic evaluations in Europe. And typically that includes productivity losses from work hours that are lost or work days that are lost. And those accrue to the economy as a whole, but also to specific employers. Of course, it's again a different or a difficult ethical debate if you want to split up who's on the side of the benefits and make them responsible for payment if it doesn't cover all the patients. Not all the patients are employed, so that there is good reason to argue that way, that employers do have considerable benefits, that they should foresee preventive measures like Tamiflu or even flu vaccination or other vaccines for their employers. But there are equally valid, from an ethical point of view, I think, arguments to say that this is something that befalls all of us in society, not just the employers, since they are contributing to the whole of society. So that's a philosophical debate, I think, but not very obvious, I'm afraid.
Okay. Chris, do you want to add anything or make another comment about something else?
Just to say that, my personal view, and again, it's a personal view, is that the health service should pay when there's good evidence of meaningful benefit for a relatively cheap intervention with low side effect profile that does help people function better and improve their quality of life, as Philippe has shown. But a final comment, I guess, from me is just to add to the point that Lenny has made, that this trial, the ALICE trial, led to the development of a platform trial which is ongoing in the UK at the moment, called the Principal Trial of Community Treatment for COVID-19, and that will no doubt become a sustainable, or we hope for it to become a sustainable platform trial also for looking at influenza, because a big chunk of missing piece of this jigsaw is the early treatment in the community, where really the goal of society should be to make people ineligible for Lenny's trial, if you see what I mean, by giving them early treatment so they never have to get into hospital. But we don't have a Europe-wide platform trial for that, do we? But we do have a trial that is hoping to develop into that role, and an early treatment platform trial in the community is existing now, and hopefully will be expanded. But we couldn't have done that within the pandemic so quickly if it hadn't been for the work of PREPARE and the far-sighted funding from the European Union.
Absolutely fantastic. So just in the last 3 minutes, I thought I'd just ask any of you if you'd like to make a final remark. There's a question which has been posted from Heather Sampson, which was, what's your favorite finding to date? This rather reminds me of, which of your desert island discs would you save? So I don't know, Cosimo, can we go to you? Anything you'd like to say finally, or do you want to name your favorite finding in the pandemic, the thing which has really woken you up?
Oh, wow, that's I still have to find it.
Okay.
I'm still working hard to find the finding that, yeah, I can define my favorite.
Okay.
Maybe I won't find it for this, pandemic, actually.
That's what science is like, isn't it? Anyone else like to make a final comment, or Alistair, if you want to?
Just to pick your question, as an ICU doctor, I thought the thing that probably the most interesting was the remap cap and steroids. Steroids have been a treatment looking for a disease for about 20 years in ICU, and COVID provided us an opportunity within remap and also with other trials, recovery and others, to do meta-analysis to show that it actually was effective and became a cheap, effective therapy that was rolled out in ICUs globally within a short period of time and had a large impact on mortality. So I think it's a huge win for remap cap early in the pandemic, just between the first and second waves. You know what I mean? That was timely. So that would be helping my desert island discs, as you say.
Okay. Chris, do you want to?
Yeah, on a more general level, I think the example of PREPARE has really borne fruit, that this was a collaborative platform for clinical research that was exactly in the right, we did all the work, and then the pandemic came and we springboarded from it into all of this pandemic activity, which couldn't really have been done if PREPARE hadn't existed. And I think that's true of lots of the different kinds of work that we've all done, that preparatory work gets us ready for these emergency events. And I really hope that can be recognized and sustained by funders and by governments and so on going into the future.
Absolutely. Very good. Any final comments, or shall we wrap up there? Chris, are we happy? Other Chris?
Yes. Yes. Delighted. I think the points are well made, and happy to leave it there.
Excellent. Well, thank you all very much. A very exciting session, and great to see you all on screen. Let's hope to get back in person together. And thank you everyone who's attended. Very good discussion, really interesting. Thank you.